Good afternoon, everyone. I'm Dimitri Amaras, and I am going to be the host today for our penultimate talk in this Metalwork series. So today we're talking about metalwork in the spine, and we've split the talk into two different sections, one on trauma. It's been given by Dr. Elizabeth Dick and Mr. Reza Mubashiri, and one on elective spinal work given by Yaron Berkovitz. We're going to start on time, and just bear in mind, everyone, that this session is being recorded. So, Elizabeth, without further ado, I'll let you to start the talk.
Okay, great. Thank you, Dimi. So we're going to talk about spinal metalwork in trauma, and please shout out if you can't hear me well enough. So let's move on to the next thing. Here we go. So why do you operate in a patient with spinal injury, Reza?
Thank you, Elizabeth, and thank you to my moderator. The principles of any kind of spinal operation, in this case, with the setting is clearly trauma. Of course, Yaron's going to be talking about elective surgery after our talk, but in the context of trauma, is really all about stability, and the stability. First of all, has to have a definition, and one of the best definitions was from the 1980s by Punjabi and White. And basically, it's the task of a bone, in this case, the spine, to be able to withstand physiological load. And if it's not able to do that, then it could deform and cause neurologic injury. So first and foremost is to try and stabilize the spine and realign it to its anatomic shape. And if, as a result of the findings of the injury, the issue is also involving neurologic injury, that's also an ideal to decompress it at the same time as stabilizing it. And thereby you can protect the neural elements as best you can to allow a good environment for the bones to heal in a natural or anatomic shape as possible. And then ultimately, any kind of fracture, including a spinal fracture, is very, very painful. And of course, it may help the pain of the patient because an unstable injury may cause extra pain. Pain itself, as the only indication for an operation, is a soft one. And so we tend not to use that. It's really when we have a clear, identifiable instability. And hopefully we'll see in the next few slides about that.
So, and the most common operation that you do, Reza?
Well, the most common one that you'll see in this context is going to be pretty tried and trusted posterior decompression and fixation. And by far and away, the most common way of doing that is to insert pedicular screws.
Okay, good. So we're going to go through this checklist. This is the checklist we're going to be looking at all the way through this teaching session. So whenever you're looking at any post-operative imaging in the spine, you start off by mentioning where the fixation is, what level and what type of fixation it is. Then you look at whether the metalwork is well positioned in the bone. You look at associated fractures, look at restoration of height and restoration of alignment, and then you think about things like neurovascular compromise and soft tissue injury. So let's go through the first patient. There's 10 patients in total to go through. This is the first patient who was in a high-speed road traffic accident. They've got a 3-column injury of L5, and you can see on the sagittal image how there's loss of height there as well. So we're concerned here, aren't we, about the risk of progressive neurological injury. So this patient had pedicle screws inserted. And Reza, I'm actually going to ask you if you could walk us all through how you do this, please.
Sure. Well, in this case, as Elizabeth says, this is the person who's got a 3-column injury, and there's a specific subtype of classification on the AO classification for these injuries. And of course, this is not only what I would say instantaneously unstable insofar as you look at it, it's also temporarily unstable. And that means that potentially, if left alone and over the next few weeks, the position could alter drastically, and it could make it even look even worse. So the way to fix these, in this instance, the posterior instrumented fusion, is to go through the posterior tissues in a midline fashion, after the skin and the fat, subcutaneous tissues, you end up on the thoracolumbar fascia. That has to be divided either in the midline, or you can go out to the sides and use what's called a Wiltse approach to reduce the muscle injury. But one way or another, you have to get down to the bone and then identify the entry points for the pedicles. In this case, it's a 3-column fracture of the L5 vertebra, and the way to stabilize it, at the very least, would be to instrument it a level above and level below. So the L4 and S1 pedicle screws have to be visualized so that you can then put the screws in. You'll notice that these screws have got a good projection. They go parallel to the pedicles all the way into the vertebral body, and they occupy at least most of the width of the vertebral body, and that allows for changes, including distraction, to be able to be performed. After that, rods are inserted. In this case, we have curved rods because it has to follow the shape of the lumbar spine here, where there's lordosis, but there'll be sections of the spine where you just put in a straight rod. And if you don't have, or if you've got a completely smashed vertebra, as it were, you have to restore and realign it. And the way you do that is some form of distraction. And distraction basically means you pull on it on either end using sometimes instruments. This is a particular set. It's not related necessarily to the picture on the right, but this is an AO reduction instrumentation. You see there, you've got a straight rod, but that allows distraction of the ligamentous part, and at the same time, therefore, it distracts the fracture in the middle and realigns it. Hopefully, if there's been a significant loss of vertebral body height, this can help restore that just by distraction. And then once that's happened, the rods are placed and the screws are locked down at the top and bottom, and that makes it a rigid structure. That's right. That's the sort of this distraction technique.
Great, thank you. I think it really helps to understand kind of how you do the operation, and also kind of what the goals are when we're looking at the post-operative images. So in this patient, we're looking at the post-operative images, and on the sagittal imaging, you can see very, very nicely, can't you, that the pedicle screws are completely intrapedicular. They're relatively, they're certainly kind of within the vertebral body. They don't protrude too far anteriorly, but they're within a good amount of the vertebral body, correct? And then here's the midline view of the vertebral body. So in terms of the pedicle screws on the axial as well, we can see again, these screws are entirely within the pedicle. They're not too medial, so they're not going to irritate any exiting nerve root, and they're not too lateral. They're kind of perfect, basically. So that's good. So the position of the metalwork is ideal. There's no fracture of the pedicle, there's no fracture of the metalwork. But if we look at the height of the vertebral bodies here, I've just put up the pre and the post imaging. You can see there wasn't really much change in vertebral body height for this patient. And if you look on axial imaging at the degree of retropulsion, just here, so this was the degree of retropulsion pre and post, and they're kind of more or less the same. So what I've done is I've printed out the reports that we issued in full, so you can kind of see the language that various people have used. And here what we say is that there's been posterior fixation of the L5 burst fracture with transpedicular screws at L4 and S1. That the screws are in a good position, that vertebral body height is not changed, the degree of retropulsion is unchanged, but there is good alignment. So I think do you think that's a useful report for you to read, Reza? Or don't you read them much?
I always read the report. That's the least courtesy you can do. I think there's enough information there on the report. It's not too short, and it's not terribly long. It gets to the point, and so yes, I would be very happy with the report.
Okay. Good. So then this is the second patient. So this patient has a 3-column burst fracture of L1, and we've got the pre-op on the left and the post-op on the right. And certainly on the post-operative images, we can see that the pedicle screws are very nicely placed. And let me just move this out of the way for a moment here. Here we go. So going through our checklist, we mentioned all of these features, but the thing that I want to particularly ask, and so we're going to use the chat now, Demi, is what do people want to say about restoration of vertebral body height and whether or not there's been a reduction in kyphosis? So people want to type into the chat and then Dimi will tell us.
Yeah, I think if you guys, so if you just put it in the chat, I shall look out for any responses. I haven't seen any so far. Quite happy if someone wants to pipe up, seeing as we're such a small group today. If anyone wants to just unmute and say what they think. So Yaron, another speaker, has said thumbs up.
That's an excellent report, Yaron.
Yeah.
They should introduce emojis into all Chris systems.
Yeah.
Yeah. Comment on a single sagittal image on the left and compare it to the one on the right, but you get an idea of what's going on. It's definitely a multi-fragmentary or a comminuted fracture, and it's one of those pincer types which goes through right in the middle of the vertebral body. You can see that, appreciate that on once the metalwork has been put in. And so you're looking for things like how much of the anterior vertebral column height has been restored, and potentially it's been brought right back up to what would be a preoperative injury. You can still see the fracture, but in terms of the height, yes, there's been good restoration.
Okay, good. And also probably, assuming no one else has answered to me, probably
no, there's no other answers there.
A little less kyphosis, do you think?
Yes,
yes,
there probably is. You know, some of the time it's nothing to do with the metalwork that you put in, but by virtue of the fact that the patient has been put in a prone position for an operation, it tends to open up the front of that vertebral body space, and it gives the surgeon a helping hand. But yes, for sure, in this case, there's an AO fracture system that's been used, and these are sort of slightly different pedicle screws. They go through the pedicles, but they go right to the very tip of the vertebral body, and they're called Shantz screws. This is one of the best chances of distraction you have, especially someone who's got very early, you've got to them very early after an operation, so maybe a day or two since they're fractured. You've got the best chance of trying to restore their anatomy.
Great, perfect. So let's move on now to our third patient. So we're still thinking about metalwork in bone. Now this patient had a cervical spine injury. So the C5, I keep moving this around, I'm going to actually minimize. So the C5 vertebral body was burst, and there was also facet joint subluxation at C5-6. And we can see on the MRI, can't we, that there has been cord injury. So this patient went on to have decompression and stabilization from C3 to C6. And we're going to run through these images as they appear on PACS. And I wonder, as we're running through, if anyone wants to comment on what they think is going on in terms of the position of the screws. So we've got C1, 2, 3, 4, 5, 6. Don't worry about kind of mentioning which levels. I know that's a bit tricky. But what do you think about the position of the screws? Are they within the lateral masses, or are they elsewhere?
So feel free to pipe up or
to shout.
Put in the chat.
So can you talk us through what happens in the midline while people are thinking about that, Reza?
Yes, so I'll give you a brief history of this unfortunate patient. So he was, I think he came in. That's fine. So he had a construction site injury, and he came in essentially with an AJA injury, so complete neurologic deficit here, and at the time the surgeon decided to proceed with an operation as soon as possible, given that his injury and the instability. So yes, if you want to describe it, what you've got is a sort of a burst fracture of the C5,
yeah.
C5 vertebra, but there's been some retropulsion, and the MRI that Elizabeth showed you on the scan shows definitely cord contusion. You can see exactly where the injury is and the retropulsion which has resulted in that. And already you can see the cord at the level above it has been involved as well. So what they decided to do, and you can do either an approach from the front and combined with the back, or just the back alone. And the surgeon in this instance decided to tackle it from behind and do again a midline posterior, in this case cervical decompression and stabilization. And so if you look through the midline, you will see the skin clips from the operation, and you can also see that that spinous process in the laminae, which is the level of the injury, the decompression has been done. And of course, then the metalwork. And the metalwork in this instance, because it's in the subaxial cervical spine, there isn't an awful lot of room in the pedicles. And with the exception of a few of our colleagues, especially in countries like Japan, who tend to actually put in pedicle screws in the cervical spine, the vast majority of surgeons internationally would use the lateral masses, because the lateral mass is a great chunk of bone which you can put screws in. And so this is lateral mass fixation of the subaxial spine from C3 to C6. And then obviously in terms of comments, if you want to say, Elizabeth, what you think?
Has anyone sent any comments about what they think of the position of the lateral mass screws?
So we've got a comment from Marcella suggesting that the screws are through the facet joint and potentially impinging on the foramina.
Yeah, that's exactly right, isn't it? So we can see the screw here. This is C3, 4, and C4, 5. Those facet joint screws, sorry, those screws are actually in the facet joint. As you say, Marcella, they're kind of protruding anteriorly into the neural foraminae and potentially protruding on the exiting nerve roots. So that's not optimal. And then we can see the same on axial imaging as we come through. Just shout if you want to say anything specific, Reza. Here we are. This is the level of C4, I think. And then C5 is here. And the screws in general, what do we think about the position of the screws here?
Well, the starting point for all those screws is good, but unfortunately, they're all too low. I mean, there are 8 screws there, and probably at least 6 of them actually are too low, and so they end up actually in the joint rather than in the lateral mass where they belong. And again, you can see because it started off too low, it ends up in a neural foramen in multiple places. So you have to kind of question the stability of the implant there itself. And so yes, I don't think there's not many complimentary words you can say about that fixation.
Okay, good. So that is that patient. I'm going to put these in as well. So what we said is that the lateral mass screws are within the facet joint, also extending into the neural foraminae. Okay, so next patient I want to show you, we'll speed up a little bit because I'm conscious of time. This patient actually did have an elective operation, but we're showing you this because they have a complication that you can see acutely. So as soon as they had their L5 S1 fixation and they woke up, they had left S1 nerve root symptoms immediately. So they came to CT. And here we are, this is the level of L5, and here's a pedicle screw on the right, here's the pedicle screw on the left. Would anyone like to comment on whether they think the pedicle screw on the left is in a perfect position? Is it too medial? Is it too lateral?
So no comments so far on the chat. I mean, if anyone wants to pipe up.
So we'll wait a little bit of time.
So Yaron and Marcella both think they're too medial in terms of the
yeah, exactly right. So this screw here is definitely too medial. It's crossing the lateral recess. And so it's very, very likely that it's rotating or traversing left S1 nerve root. So probably that screw has to come out, correct?
Yes, that patient woke up immediately with symptoms and then they proceeded with a CT scan. So already the clinician and the patient are both concerned. That would have to be a straight, revision of screw fixation to allow the patient the best chance of getting the symptoms to resolve. Okay, good.
So thinking a little bit more about neurovascular compromise, I just want to show you this patient who fell from a height. They've got a 3-column injury at 2 levels in the lower lumbar spine. And let's have a look at the posterior fixation in this patient and particularly at the screws. So I know that you said it's important for the screws to be kind of well engaged in the vertebral body, but the screws in this patient protrude a little bit anteriorly, don't they? And we can see that they're relatively closely related to the common iliac artery, although the artery is fine. But that's another thing to consider. And also to kind of word quite carefully, I suspect, the report. What do you think?
Yes, I think so, because there's more comments that you can make. Actually, the lowest level of the fracture was L5, so it's unusual that the fixation has actually ended in the L5 position anyway. Most people would decide to go down to the sacral vertebra to S1 to bypass the injury. And then, of course, we have this slightly long screw. It starts off well. It's following a sort of a fairly straight trajectory compared to the other one, because you could medialize it quite a lot more to begin with, so it follows. So it needn't necessarily have been long. It just looks long because it sort of started off initially in the wrong place.
Okay, so that's useful. So on to case 6 now, and this patient had a fall from standing. They acutely were unable to raise their arms, and you can see that actually they've had a hyperextension injury at C5-6. They've torn the ALL, they've got cord contusion. So this patient had posterior decompression from C3 to C7, and when they woke up, they had right C5 nerve root symptoms. So I'm just going to show you a segment through the right C5 level, and here's the lateral mass screw here. And I just wondered if anyone would like to comment about the C5 lateral mass screw and its relationship to the neural foramen. Here's the neural foramen, obviously. And here.
So no comments yet, but I think it's been well exemplified by those images that you've shown.
Yeah, so we know, don't we, obviously, that the neural foramen at this level is the one with the C5 nerve root. So already I think clinically we're suspicious that there might be some irritation. And so actually really what we're seeing here is that the screw tip is a little bit too anterior and protruding into the neural foramen here. So I think the way that we worded our report was we said that the right-sided lateral mass screws in C5 protrude slightly, and so the exiting C5 nerve root could be irritated. Okay, moving on. So this is a patient who has a rigid spine. Actually, it's quite interesting, as Reza pointed out to me. He's not only got DISH, diffuse idiopathic skeletal hyperostosis, but he's also got OPLL, so ossification of the posterior longitudinal ligament that we see here. And obviously he's got central cord contusion. So, you know, I would say as a complete amateur that actually this looks like it might be quite a hard thing to fix. But I put these images up to show really kind of what the optimal position of lateral mass screws could be. So Reza, I wondered if you could just talk for us for a moment about the C2 and the C3 intrapedicular screws.
Yes, yes. The context here is sort of a dual pathology of, well, 3 pathologies, the OPLL, the DISH, as well as the fact that the patient has probably had an injury by falling and opening up the anterior part of the neck. And so the surgeon's strategy here was, rather than doing anything at the front, to go through the back. And as we're in the subaxial spine mostly, but also C2, from C3 downwards, you can actually put lateral mass screws. And so you can see at C3, the picture on the right on the bottom, you've got divergent screws that look pretty well positioned on both the sagittal and the axial planes. And then in C2, level above, I think, why are they now converging? Well, the anatomy is different there, and you have to instrument that differently, and there's a variety of ways. And so this is actually PAR's sort of a pedicle entry point, a C2, which works very well and gives you good purchase. Although if you didn't have that, you can use laminar screws. But in this case, you've got, that's why you've got convergent at C2 and divergent at C3, and they're both right. And we can see on the sagittal that, save for the fact that the rods are slightly long, you could even go down to C5 with that fixation. But otherwise, it's pretty sound fixation.
I wanted briefly, while we were talking about rigid spines, to talk about cement, which is used to augment the fixation, correct, Reza? So here's an example of a patient with Angst-Bond who has a flexion extension injury and a long posterior fixation. And what I've put this up for is to show the cement around the screws. And the aim of that is basically to help, because the patient is very osteopenic, to kind of help the screw kind of fix inside, correct? And but the other thing I wanted to draw your attention to with this patient is there's been a little bit of leak into the disc space, which doesn't matter, correct? Mm-hmm. And there's also been a little bit of leak into the canal, probably.
So Elizabeth, if I can just take a moment or two. As probably Henry VIII said to each of his 6 wives, I won't keep you long over this slide. The picture on the left is clearly a patient who's got bamboo spine, ankylosing spondylitis. And this age group, and I'm just assuming that they're elderly or at least beyond middle-aged, is that you have the dual problem of having a stiff spine and an osteopenia. Just bad bone, and the only, in fact, part of the good bone is the surface. That's the hardest bit before you get into what would be mush. So they pose a challenge in themselves in terms of fixation, and you have to use multi-level fixation above and below. And in this case, that's the reason why we use cement. And cement, I'm afraid, as the population gets older, is becoming an increasingly more popular way to fix spines, that you feel that you would enable better pull-out strength of the screws themselves. So it's not just good putting long, thick pedicle screws in. Sometimes you have to put cement in to get that interface between the bone and the screw. And in this instance, you can clearly see a leak over on the right side. Now, it may or may not be actually in the disc space. It may have just gone into some of the veins. But slightly more concerning is that arrow at the top, which shows a little streak of cement. And that's either sitting in the canal itself or it's gone into a vein system. And I'd be interested to see slightly more proximal to this X-ray and see if there's any more cement that's tracking its way up back into the general circulation of the heart.
Last 2 cases. So just I want to think about soft tissue. So this is a patient who had 3-level posterior fixation. We can see the X-ray here, but they were not very well in general. You can see why on the MRI, because on the MRI, what we can see is that there's this big fluid collection posteriorly, which basically is kind of a mixture of kind of fluid material, isn't it? Which is actually compressing the thecal sac and the chorda equina. And again, we can see on axial imaging at 4 different levels, when we get to the point of the kind of maximum collection, that thecal sac is pretty compressed, isn't it? So for this, probably MR is the best imaging modality.
Yes, absolutely. Because it depends what the clinical question is. This would, colleagues, decompression and fixation, and I think probably the patient would have woken up with some, neurologic deficits, and they would have proceeded with an MRI scan rather than a CT, because they were, rather than checking the screws, they were more concerned about is there a collection of blood or fluid or whatever that's causing continual. So your focus there is to actually look at the soft tissues and see what the state of the thecal sac is like. Although, of course, then you can see the imaging and the signal you're getting from the screws themselves. And so it depends very much the question that needs to be asked clinically.
Okay, good. And finally, thinking about more long-term complications. So this patient, should we just go with this patient because I'm just worried that we're running out of time a bit. Can we run on 5 minutes? Is that okay?
Yeah, that's fine.
Okay, good. So we have 2 more patients. So this is a patient with an unstable fracture of 1, 2, 3, 4, 5, C5, and this patient had a cage fixation. So we wanted to show this really to talk about the principles behind cage fixation.
Well, not everything is fixed from the back in trauma. In fact, quite a lot of the time, an anterior fixation is the more elegant and a sort of less morbid operation to do. This was a young man who had a rugby injury on a weekend. He was otherwise fit and well. He went headfirst into a tackle in the scrum. He came off the worse for it, and you can see he's got a burst fracture of the C5 vertebra on the previous image. And already the canal was slightly compromised, although neurologically he was intact. And so the possibility here is that he would have, as with time, if he was conservatively treated, potentially a worsening of his loss of lordosis, and then potentially more compression of the spinal cord and canal at that level. So anyway, the fixation that was done was an anterior, and in this case, it's a corpectomy of the C5 vertebral body, and in its place has been placed a titanium cage. And that cage is, in this case, one that you can You can alter the height of the cage to very much fit the end plates above and below. So it's sitting on the inferior end plate of C4 and the superior of C6. And a supplementation of bone graft has been applied both inside the cage and around it. And then finally, the fixation of the plate, again, titanium plate in this case, with 2 screws above and 2 screws below to protect the cage while it's setting. So that's quite a stable construct.
Okay, good. So we've got that, and we can see that's the same thing really on the post-operative images. So the very last patient that I want to take you to is a patient who's got a long-term complication of their pedicle screw. So this was the image on the left, which is immediately post-operative, and everything looks good. And then on the right, level of L4, you can see that they're developing a complication around that screw. Does anyone want to say what they think is going on?
Come on, guys, last one to try. Anyone?
What do we think of this kind of gap around the screw? We've left a little. Yay! Exactly. So there's loosening here, isn't there? So loosening of that right L4 pedicle. Okay, great. So basically, there's lots of things to think about with the spine. Thank you so much, Reza, for all your insights. That is kind of really what makes the difference. That's it.
So thank you very much, guys. That was an excellent talk. I really enjoyed it, and there's some really interesting cases there. We've got one question, which is about the cement problem, which is what would you do if cement goes into the vessel or epidural canal?
Yes. Well, there it's actually a conversation between you and in this case, the anaesthetist, because your chief worry there is actually, are there going to be any cardiopulmonary problems as a result of this? There's some studies that have shown, CT-based studies, that the incidence of cement leakage is exceedingly common, especially with more of these vertebroplasty techniques rather than kyphoplasty. And the reason for that is that cement has a variable working time, and people sometimes tend to put the cement in when it's too wet. And when it is, its viscosity is rather different. And so it can shoot into areas of least resistance, in this case being vessels. And so you have to adopt strategies in order to try and put cement in when it's a bit safer, when it's beginning to get a bit more solid, and that's why we use slightly more high viscosity cement. We put it in late. But yes, if in terms of doing sort of damage limitation, as soon as you detect, and by the way, when you're putting the cement in, it's something that's done under fluoroscopic vision with live imaging. And so you're as careful as possible. As soon as you detect the cement has gone in, I think you tend to stop, have a chat to your anaesthetist, make sure the blood pressure, the breathing, and everything that the patient's vitals are okay before you actually carry on. But don't stop.
Brilliant. Thank you. Well, thank you very much. We haven't got any other questions, just lots of comments saying how useful the talk was and really interesting cases. So what we're going to do now is move on to our next speaker, who is coming from us from Oxford, and it's Yaron Berkowitz, who's used to be an ex-fellow here at Imperial, but now is one of the radiologists in Oxford, and is going to give us a talk about the elective work. We're hoping that Mr. Mubashu can stick around for a couple of minutes to just pass any comments, but we know he has to go just before the end of this. So over to you, Yaron.
Thanks, Demi. Thank you very much to the previous speakers, and nice to see everybody again. So apologies, this is my first Zoom lecture, so I feel like I'm looking at a wall in front of me rather than the normal audience, but we'll do our best. So fortunately, there's quite a lot of overlap. I'm doing spinal imaging from more from an elective point of view. So we're doing the title of the talk is Alignment as Shown, Post-Operative Metalwork and Spine. But obviously, there is inevitably going to be overlap with trauma imaging because the principles of fixation and of surgery are very similar. So there's definitely going to be overlap, but hopefully that repetition will be useful. Sorry, apologies. I'm actually just starting a timer because I'm very conscious of time.
Don't worry, I can keep you to time.
You think that? So I just want
I never could when you're a registrar. Yeah.
Exactly. A very big thanks to the spinal surgical consultants at Oxford, because all of these cases have been accumulated over the last couple of years that I've been a consultant there. And these are all real cases. And in particular, one of the surgical registrars, Lieutenant Commander Tom Stevenson, who gave me some of the names for these cases, and I promised I'd give him credit. So I put a little picture of him there. And also just thanks to Imperial, the old Imperial and now King's team, who I know and miss. So today we're mainly going to be discussing elective imaging. I want to give some indication of why we operate, of the surgical indications. I'm going to give you, I want you to come away with this with some awareness of the different types of metalwork and therefore what they should look like on X-ray and on imaging, because it's very hard to make sense of unless you know the metalwork. And also, obviously, we're going to look for complications and what imaging we should do for different complications. So the indications for elective surgery sort of broadly fall into a few categories. So one of them is pain. Now, pain is a debated topic in terms of its benefits for surgery. So in Oxford, for example, they don't do very much pain surgery. But pain is where surgery can potentially benefit patients, is where their pain is definitely coming from some sort of discovertebral instability or facet instability, where stabilizing those areas can reduce pain, as well as, and I thought I'd just draw attention to the lytic spondylolisthesis instability as a separate and special entity, because that can be progressive and also painful. So the more common reasons that there's less debate about, shall we say, with regards to surgery is the neurogenic dysfunction and neurogenic pain. So that can be because of essentially narrowing, so squeezing on a traversing or an exiting nerve root, as well as squeezing on the central canal, which would cause compression of the cord equina or of the cord. And then other reasons would be tumor, as well as deformity correction. So the surgical principles broadly fall into decompression. So, and this is what you're trying to do in both the elective and also the trauma setting. So it's basically you're looking to decompress and remove any narrowings, as well as stabilize and fixate the spine and try and restore some sort of normal anatomy. And then I've said removal of vertebral body there as well, as because in tumor you'll end up needing to do that, or if there's lots of debris or retropulsion. And there are different approaches that surgeons use, and the different approaches is basically where the metalwork ends up. So there's an anterior approach, which is an anterior, like lumbar interbody fusion, or an ACDF, which is an anterior cervical discectomy infusion, or there's a lateral approach, which is an extreme lateral interbody fusion, or a posterior approach, such as a posterior interbody fusion. So, and you'll hear surgeons say things like A-lift, X-lift, T-lift, ACDF, and they're talking about different approaches when they talk about those things. So in Oxford, we use a variety of tools. So I'm trying to remember the name of this particular one. Some of these images are from the Globus Coalition cage and Optech system. So these are images that I just got from their website, but you can easily find out what your surgeons are using. We also use NuVasive, USS fracture kits, Johnson & Johnson, and Dupuy AO spine. So there are lots of different manufacturers, but all of them have images of their metalwork. And you can see that. So this is for cervical work. So these are what you use for an ACDF. And you can see this area here is going to go into the disc space. And then you've got screws to fix it into the vertebral bodies above and below. And some of them have 2 screws. Some of them have 1 screw. Sometimes the screws are different. You get different types of anterior plates, some of which have got 2 screws either side of the midline, as well as sometimes just having a single plate with screws. This is for the tools at the top here are usually for lateral approaches. So this is a lateral plate across the vertebral bodies. This is a lateral screw fixation with a spacer device. And this is just a nice picture to show you the kind of extensive metalwork you can see in elective surgery. So this is an occipitocervical fixation where you've got the plate on the occiput, rods coming down and rods coming down connecting to the screws, which are placed between through the pedicles. And this is sort of very fortunately been described quite nicely by Dr. Dick on the previous talk. So she went through that in more detail. And in the lumbar spine, again, you've got these screws that are going into the pedicle. That's going to be coming through here into the vertebral body too high, and you'll hit, you potentially impinge the exiting nerve root of the one above or of the level below, and then medial and lateral. Lateral, you're just not going to be in the vertebral body and may hit vessel. Medial, you may hit subarticular recess or lateral recess. So sometimes I say subarticular recess instead of lateral recess. It's just because neurosurgeons and some surgeons differ in their terminology, but it's the same thing. And then these are some cage devices, and you'll notice that these are often used in corpectomies. You'll notice that the central component of this cage is hollow, and that's where they'll put graft material or sort of bone substitute material. And that encourages fusion across that site. So hopefully you'll get an interbody ankylosing and interbody fusion. And then obviously there are, we've got cervical, thoracic, lumbar, but at all different areas of the spine, we're using the same principles. We're trying to decompress, fuse, and correct alignment. So let's look at some of the operations, some of the way that things can appear. We've got, this is a classic case, a patient who's got a cervical disc / osteophyte bar. They've got myelopathic symptoms. They've got 2 levels actually that are involved. We're a slightly parasagittal area, and they had both areas fixed. And you can see this is one of those original plates with just a single screw going into the vertebral bodies above and below. So 2-level ACDF fixation. This is another case where the patient has had an ACDF at the C3-4 level, but they've also had plates applied to their 5-6 level, which is fused as well as a posterior decompression. And because they've taken off the back of the vertebral bodies, they've had to fix it from the back as well. So they've got both rods and screws in the back. You can't see from this, but they've had a posterior decompression, and they've also had this anterior metalwork. And the chances are, if you see metal on both sides, it's because they've taken away the bony supports at the back. This is an interesting case. So this is a patient who's got this compression at C5 to C7, but you can see that the compression isn't just disc, it's all bone. And so this is the preoperative imaging. And this is the postoperative imaging. So postoperatively, there's something anteriorly. You can see screws going to the vertebral bodies. There's something in the interbody area. The bone has been removed, and the posterior aspect has also been decompressed. So they've had an anterior fusion with a corpectomy, which is the removal of the vertebral body, as well as a posterior decompression. And this is because they've done the posterior decompression, they've had to fix the back. And because they've done an anterior decompression, and removed some of the vertebral body, they've also put cage in situ, a cage at the front as well. And corpectomies aren't always complete, so you can actually still see this vertebral body. But on the MRI, you can see that they've removed some of it. So what they've done here is they've removed the central component of the vertebral body, but left the far lateral components in situ. And that way they've still got some bony construct to work with. And this is an example of someone who's got C1-2 dissociate or C1-2 instability. They've got bacillar invagination, and the canal is significantly narrowed here. And so for this, we're going to need to stabilize, because we're going to need to decompress and remove the back of the C1. We're going to need to stabilize. So they're going to have an occipito-cervical fusion. So the fusion goes all the way from the occiput down the back, and they've decompressed posteriorly. So if I show you here, the back, this is the C1 process on the axial. The back of the C1's been completely removed, and they've got this metalwork in situ going from the occiput down to C5. And that's the canal has been decompressed, but that C1-2 is still dissociated. And obviously, I just brought up an example to show how extensive some of the metalwork can be. So this is a patient who's had a revision surgery. They've had an original surgery of the thoracolumbar spine, then it's been extended cranially, then extended caudally. And this fixation goes all the way into crosses the sacroiliac joints and fixes to the iliac bone. So they've got a completely fused spine from top to bottom. With regards to the metalwork conversation we were having before, so for deformities, scoliosis obviously is a condition that mainly affects, or rather that we operate on mainly in the pediatric population, and kids grow. So there's a system called the MAGEC system, very clever play on magnetic and magic. And what they've done here is, this is the original scoliosis. So they've got this right convex thoracic scoliosis. They've done a fixation, and these are magnetic rods, which they can adjust using magnets, basically. And over about 6 years or so, so from about the age of 12 to 18, I think it was, or 12 to 16, they have been, you can see they've been extending this rod. So you can see more of a loosened area here as they've let that rod come up. And then eventually when they've stopped growing and their physes are fused, they've converted this to more definitive metalwork. And as well, we have tumor surgery. So this patient had a compression from a pheochromocytoma, which was decompressed. So they've had posterior decompression and fusion. Again, another patient, oh, and sorry, I just wanted to, no, that's fine. Again, another patient with tumor that's causing compression or impending cord compromise. And they've, because this is in the thoracic spine and higher up, they've done a lateral approach. Because they've come laterally, they've only fixed on one side of the spine. They can't come anterior, and they haven't come posterior because they wanted to do a corpectomy. So they've removed the vertebral body, removed that area of stenosis, and fixed it. And in terms of metalwork, this is a nice case I just wanted to show, because in tumor work, we often perform radiation therapy, and that means that we can't use titanium or steel rods. So if you look at this, you might think, oh, this patient's had their metalwork removed. They've got lots of ghost tracts in situ. But actually, this is a carbon fiber construct. So it's not completely radio-opaque. You can just make out the screws, which have a radio-opaque component to them. But actually, there are rods in situ. And what they've done across the gap, instead of putting a cage, which they can't do here either, they've put a rib strut at the back. So you can see it here. And they'll often put multiple bone allografts or autografts in. So in terms of the complications, and I think I'm still okay for time if you allow me to run over a little bit. So obviously, so what was that, Demi?
We've got plenty of time.
Okay, great. So I like to think the complications usually come in your immediate complications, subacute and chronic, right? You've got your immediate complications. What has the surgeon done that's going to cause an issue? And you know, credit to the surgeons, it's usually because of incredibly difficult operating circumstances. So you know, you've got your bleeding, CSF leak, or incorrect screw placement, right? Then subacutely, and sometimes this is the subacute complications are actually issues that occurred at surgery but present late. So we've got construct failure. In other words, we haven't stabilized enough and you'll see failure. We've got bleeding as they start to mobilize. CSF leak often is something that occurs at the time of surgery, but they present later on with headaches a few months down the line, and of course, infection. And then chronically, we've got adjacent level disease, infection, loosening, and long-term issues with the biomechanics. And the imaging that we do for those complications depends on what we're looking for, and it depends on the presentation. So does the patient have mechanical pain? Are we worried about the construct and the metalwork and adjacent level disease? Or are we worried about infection? Or are we worried about nerve problems? So I think that if we're wanting to know what the alignment of the patient is in a physiologic position, i.e. standing or sitting, we need to do x-rays, because we can do x-rays while they're stood up. And that'll also show us the metalwork and the gross positioning. So that gives us an idea of the patient's alignment and metal positioning. If we're worried about collections or the soft tissues, basically, so collections or nerves or discs, we need to do an MRI. And if we're worried about the metalwork and we need more detailed imaging of the metalwork, we need to do a CT. And often you need to do an MRI and a CT together, because metal can impinge on nerves. So we need to see in detail where the screws in the metalwork is. So this is an immediate, a patient with an immediate complication. You can see that they've had a cervical posterior fixation, and this screw is just a little bit too lateral when you look at the X-ray, if you look at the others. And cervical screws do often go in a slightly more lateral direction, because they don't want to, that's the direction of the pedicles. You can see that this is a laterally placed screw. Unfortunately, this patient didn't have any problems with that. But if that screw is too far lateral, it's not in bone, and that means that they could get a construct failure, which this patient actually did get, and they then had to have a revision. This is a case of another immediate complication. So if you look, this is a patient with a deformity, they've had a scoliosis fixation, and then all of these screws are quite pointing inward towards the vertebral body, except for this one, which is pointing outward. And if you look at the 3D reconstruction, there's one screw that's just gone lateral to the pedicle, lateral to the vertebral body, and it's nicely embedded in lung. And so the question becomes, what do we do about this? And basically, if the patient doesn't have a pneumothorax at that time, the surgeons generally will leave this in place, because if you see it immediately, you might take it out, as in at the time of surgery or immediately post-op. But if you've seen it only after a week or so, or even after a few months, it's best to just leave it in. Our surgeons decided on this case because it forms scar tissue, and as you pull that screw out, you're potentially going to tear the pleura and give them a problem they currently don't have. Oh, sorry. So this is another much more subtle case of an immediate of a screw placement issue. So if you look, all of these screws are pointing inward, but on the other side, you want to see that the screw doesn't go beyond the vertebral body. Now, this hasn't projected very well, but the vertebral body edge here comes down to this side, but on this level, the vertebral body edge actually comes here, and you can't, basically, they weren't sure that the screw was in the correct position. And when they did a CT to check on that, they could see that in fact it wasn't. Now, fortunately, in this case, it hasn't hit any vessels, but these can obviously, misdirected, approach the aorta, and I have seen some which touch the aorta, or I've never seen one go into it, fortunately. And this is a nice example of another immediate complication. So I wanted to show these images, not because the complication is seen on this, but just to show you what these carbon fiber constructs look like. So this is a patient who's had a tumor removed. This was a chondrosarcoma. They've had a corpectomy. They've had a removal here of the vertebral bodies. They've done this a lot, quite broad fixation, 4 levels below, 3 levels above. And they've also used a bony allograft. And this is actually, if you look at the shape of it, this is a tibial allograft. You can see here. And that's going to provide some strength, and that's hopefully going to incorporate and basically provide fusion. But on the MRI, you can see that there's a very large fluid collection, and it's very, very fluid signal around the allograft and around the vertebral body. So this is the cage device they've put in. You can see here, nicely caged, filled with bony material. This is the cord slightly pushed to the side. So this was an immediate pseudomeningocele CSF leak. And actually the patient settled down. But sometimes in these patients, these CSF leaks, sometimes they'll treat them conservatively. But if the CSF leak communicates with pleura or is quite high up, as the patient creates negative pressure in their chest and inhales, they can get constant sucking on that CSF into the pleural space. So sometimes they do have to go back in and repair these. So I apologize, this is a trauma case I've stolen from Elizabeth's theme. This is a patient who had a burst fracture. They had it operated on with posterior fixation and decompression, but then immediately post-op, so this is on table, but then immediately post-op, as they started to mobilize after a day or two, the screws fractured and they got immediately recompression. So you can see here, it's got good reduction, but here it's collapsed again. This is another similar, and then they had to extend the fixation. So these are the fractured screws, and they put a cage in to restore height this time, fixed from the front, fixed and extended the fixation at the back. This is a similar case, so fracture, fixed, and then as the patient stood up, and this is the point, I've reversed the image, but that says standing. You look in a mirror. So as the patient stood up, they've collapsed down because the rod's basically just bent, or the screws might have pulled out slightly. And they had more definitive fixation with the cage holding things up. This patient presented subacutely. So the complication was at the time of surgery, but they prevented subacutely. They did radiographs. checked that this is an L5-S1 fixation. They've got a disc device in situ, and they saw on they did radiograph surgery, which didn't show anything, but on the CT, they saw that this right S1 screw is touching the nerve root. Now, normally, if the patient didn't have symptoms, you might comment on it, but you wouldn't say, I wouldn't report this as is irritating the nerve root. I'd report this as is contacting the nerve root with potential for irritation. But if they've said to me that they've got sciatica and they're worried about that nerve, I'm going to say that it's likely, or that this may be the cause of their symptoms. And as another example, I apologize, the windowing is difficult, but I circled where the nerve root was on the windowing. You can make it out on this side. So this is a different example. Again, the screw is just traversing the lateral recess, touching that S1 nerve root. Same thing, I would have commented on a possibility, but not said definite unless they had sciatica. So this is a patient, like I say, with regards to the presentations that can be subacute from an immediate problem. They had a thoracic fixation. They started getting head drop, and they started getting adjacent level problems. So they extended the metalwork into the cervical spine to bring the head back up. But unfortunately, when they did that, at the time of surgery, they developed this large posterior collection. So they actually presented several months after the surgery. So this is months later, showing this collection, which is from CSF. So they've got this a chronic, slow CSF leak. Another case, which is subacute. So this patient had an L4 to S1 fixation for an lytic spondylolisthesis. And I just wanted to, this is just to highlight the fact, what you look for instability. So for instability, which can occur at different times, you can get screw fixation fracture, you can get loosening, but the other thing you can get is gas in the intervertebral spaces. So if you see what is gas, which is vacuum phenomenon, that suggests that they've got some ongoing movement at that level. So we've got two signs that tell us that there's instability at the L5-S1, fractured screw and some vacuum phenomenon. I do appreciate in this case it's very subtle, but it's often more obvious than that, but you can still be relatively confident. And this is a case of, so I'm just going to say what this is because just from time, this is infection. So this patient had a scoliosis which was fixed, and they developed an infection that the team actually knew about. And what they were trying to do was leave the metalwork in for long enough for the patient to fuse so that they could take the metal out. Because if they take the metal out early, the deformity is going to come back. So you can just appreciate there's some lucency here at the bottom screws, but when you do the CT scan, there's lucency, which could be loosening or infection, but the sclerosis around it is suggestive of a chronic infective process. And when we do the MRI on this patient, there's fluid crossing the vertebrae, lots of edema, and then there's actually a collection which comes down to metalwork here and surrounds the screws. And there's this big subcutaneous collection. So this patient actually had a sinus that was discharging, which is why they were actually doing well with the infection, because they were getting rid of that fluid. This is another chronic complication. So they've had an ACDF. And if you look at these levels C3, 4, as time has progressed, they've developed adjacent level disease and degeneration. So, which means that they're probably going to have to fix that level in due course. This is a very unusual case, which is what I wanted to show it, of adjacent level disease. Patient had a fixation done. They had a posterior decompression, posterior screws in situ because they've had to decompress posteriorly, and they've been holding their head up with a fixed C2 to C6, I think it is, and they've developed a C1-2 adjacent level disease where the ligamentum flavum is now indenting on the cord and causing a myelopathy. So that's very unusual, but a very nice case. And this is, yeah, so this case is actually, I think this is my last case. You'll be very happy to hear, Jimmy. But this is one of my favorite cases. So it's a patient who had a scoliosis fixation, and they had this fixation in situ for a few years and started developing pain. So this is their original, this is their post, their imaging from a few years later. And if we look at some of these screws are a little bit lateral, but it wasn't convincing at the time of taking the radiograph. So we did a CT scan to look at the position of the screws. Now, if we first look at the coronal imaging, those upper two screws are a little bit lateral. So you can see they're not pointing inwards at the vertebral bodies. They're a little bit lateral. And it's hard in scoliosis because there's a rotational element to the deformity. So often they'll have to change the direction of the screws because the patient's got such a significant rotoscoliosis, rotational component. And as a result of these screws not providing much fixation of strength, there's loosening of the upper screws. So you can see this lucency surrounding the most cranial right screw. I think it's T1. However, if we look at another parasagittal image, so same screw, that lucency actually extends anterior to the screw all the way through the vertebral body. Now that is very unusual for mechanical loosening. So it raised the possibility of a few things. So the differential, in this case, the things that we were thinking about were infection, or if this could be some sort of an aggressive granulation tissue destroying the bone in front. But the other possibility that could occur, which is less unusual, if we look, the screw has breached the medial wall of the pedicle. Now, at the time, there was no CSF leak seen, but even if CSF can track along that screw, the CSF has a pulsation effect. And because of that pulsation, it causes basically erosion of the bone in the same way that you can form a ganglion cyst when you've got subchondral loss or a fissure. It's that constant pressure. So eventually you can get erosion of the pedicle, of the bone around that screw. And in this case, it's erupted anteriorly. So even when the medial wall of the pedicle is breached and there isn't any loosening, you can still get mechanical loosening, that is. You can still get lucency forming around that screw if it's in communication with the CSF. So in summary, know your tools. So know what equipment your hospital is using. Keep in mind the indications of surgery, mainly being pain, neurology, deformity. What we do for surgery is usually always the same. So it's decompression, fixation, and correction of deformity, and removal of tumor if there's tumor. And then keep in mind the different complications and when they occur. So we've got our immediate complications, bleeding, CSF leak, screw positioning, our subacute complications, often CSF leak, infection, loosening, and our chronic complications like infection, loosening, adjacent level disease. And the imaging that we're going to do depends on the presentation and when the patient has had their imaging done, has had their surgery done. So X-rays are going to show you physiological alignment with the patient standing upright, and that's their real strength. So even though we're going to do CTs and MRIs, X-rays are still very useful. And then CT for metalwork, MRI for nerve roots, and for collections.
Fantastic.
Thank you very much.
Thank you very much, Yaron. That was an excellent series of cases, and thank you very much for that talk. Got one question from Marcella, who said, in the previous case, what was the diagnosis of the right pedicle in the end?
The previous case in the right pedicle, you'll have to take me back.
Marcella, why don't you...
Yeah, so this case, Yaron, you said that something related with the CSF and the appearances of the right pedicle. So I missed that bit. So what was the diagnosis at the end of this case?
So we did an MRI on this case, which basically wasn't enormously helpful. It showed that this area here was sort of a heterogeneous fluid signal. So CSF pulsation artifact was still one consideration. But the other was that it could have been granulation tissue. And the truth probably, the patient had revision of their metalwork, but they were due to have the metalwork out at some point. So they didn't do histological sampling at that stage, but it wasn't infection.
Okay, thank you, great.
Brilliant. Well, I don't think we've got any other questions, and seeing as we've gone over time, I think we'll just finish by saying thank you very much to all our speakers. Both the talks today, this lunchtime, were excellent, and I've really learned a lot from them.